Welcome, aspiring medical students, to today's lecture on the topic of retinal artery occlusion, RAO. In this comprehensive course, we will delve into the complex world of RAO, exploring its clinical differences, management approaches, etiologies, diagnostic challenges, and treatment options. Get ready to embark on an enlightening journey through the intricate details of this fascinating field. In summary, retinal artery occlusion consists of two forms, CRAO and BRAO, which differ in clinical presentation and management. CRAO involves a complete occlusion of the central retinal artery and requires urgent intervention, while BRAO is a localized occlusion with a more conservative management approach. In summary, embolic retinal artery occlusion is a condition where an embolus blocks blood flow to the retina, causing sudden vision loss. Identifying the source of the embolus is crucial for determining appropriate treatment options, which may involve medications or surgery. Diagnostic tests such as fundus examination and imaging play a key role in confirming the diagnosis. Non-embolic retinal artery occlusion, RAO, is a challenging diagnosis. It can be caused by local factors, vasculitis, hypercoagulable states, or compressive lesions. Evaluation involves a thorough history and laboratory investigations. Treatment depends on the cause and may involve immunosuppression, anticoagulation, or surgery. In summary, ocular massage is a non-invasive technique used in managing CRAO. Its timing and technique are crucial for effectiveness. Early initiation and proper training are important for maximizing outcomes, while caution should be exercised to avoid complications. In the management of retinal artery occlusion, RAO, anterior chamber paracentesis has been proposed as a therapeutic option to relieve intraocular pressure and enhance retinal perfusion. The mechanism of action lies in reducing intraocular pressure, subsequently decreasing the impedance to blood flow. The procedure involves the insertion of a fine needle into the anterior chamber to drain a small amount of aqueous humor. This temporary reduction in intraocular pressure may help restore retinal perfusion in cases of RAO. Anterior chamber paracentesis should be performed by skilled ophthalmologists in a sterile environment. The risks associated with the procedure, such as infection or damage to intraocular structures, should be carefully considered before its implementation. These imaging modalities, such as fluorescein angiography and optical coherence tomography angiography, offer a detailed assessment of retinal perfusion and identify areas of occlusion, delayed perfusion, and the presence of collateral circulation in cases of retinal artery occlusion, RAO. Additionally, OCTA can provide valuable insights into the ischemic penumbra, which may indicate the potential for spontaneous recovery. Retinal artery occlusion, RAO, and giant cell arteritis, GCA, share similar symptoms and can both cause sudden vision loss. Accurate diagnosis is important as GCA requires urgent treatment to prevent complications. Diagnosis involves clinical assessment, lab tests, and possibly a temporal artery biopsy. Collaboration with rheumatology specialists aids in confirming the diagnosis and planning treatment. Neovascularization is a potential blinding complication that can arise in the context of retinal artery occlusion, RAO. Several novel treatment options have been explored to tackle this challenging sequelae. Intravitreal anti-vascular endothelial growth factor, anti-VEGF, injections have shown promising results in managing RAO-associated neovascularization. These injections inhibit the proliferation of abnormal blood vessels, preventing their growth and potential complications. Other treatment modalities include laser photocoagulation, which selectively destroys abnormal blood vessels, and intravitreal corticosteroid injections, which possess anti-inflammatory properties and suppress neovascularization. While these novel treatments offer hope, their efficacy and safety need further investigation. Collaborative efforts between ophthalmologists, researchers, and pharmaceutical companies are necessary to enhance treatment outcomes in RAO-associated neovascularization. Identifying prognostic factors for visual recovery in retinal artery occlusion, RAO, is crucial. Duration of retinal ischemia, initial visual acuity, and collateral circulation affect outcomes. Timely intervention, better initial acuity, and intact collateral circulation are associated with improved prognosis. Retinal artery occlusion, RAO, in young adults presents unique clinical characteristics and often has systemic associations that differ from older age groups. Understanding the etiologies and associations is essential for accurate diagnosis and management. In young adults, non-embolic causes, such as vasculitis and hypercoagulable states, play a prominent role in RAO occurrence. Systemic diseases, including connective tissue disorders, for example, systemic lupus erythematosus, Behçet's disease, and hematological disorders, for example, sickle cell disease, antiphospholipid syndrome, should be considered in this age group. Thorough evaluation, including laboratory investigations and systemic workup, is necessary to identify underlying causes. Collaboration with other specialties, such as rheumatology and hematology, aids in formulating appropriate management strategies and minimizing the risk of recurrence. Optical coherence tomography, OCT, provides detailed insights into retinal architecture changes in retinal artery occlusion, RAO. Acute RAO shows retinal thickening, loss of layers, and increased reflectivity. Chronic changes include thinning, increased reflectivity, and fluid accumulation. OCT aids in diagnosis and monitoring. In summary, thrombophilic disorders play a significant role in the development of retinal artery occlusion. Proper diagnosis and management are crucial to prevent complications and recurrence. In conclusion, retinal artery occlusion, RAO, is a complex condition with various aspects. Through this course, we have explored differences, diagnostic challenges, and treatments for RAO. Remember to expand your knowledge and embrace challenges ahead. Good luck, future ophthalmologists.